Welcome to NCLEX in 30. We will focus on the respiratory system. Today is not about random facts, and it's not about memorizing lung diseases. This is about learning to think like a nurse, prioritize like a nurse, and pass like a nurse. Because respiratory questions, they are everywhere on the NCLEX. And if you can master airway and gas exchange, you can answer priority questions with confidence. Here's what we're focusing on today: frameworks, so you're not guessing. You'll have a mental system to walk through every respiratory question. Priorities, which are airway, breathing, and oxygenation. And we're going to have some practice because the next gen NCLEX isn't about memorization, it's about clinical judgment. By the end of the session, you won't just know respiratory content, you will know how to break it down under pressure. So take a deep breath because today we are mastering lungs the nurse way. Let's get started. All right, future nurses, let's lock in. Respiratory equals oxygen, oxygen equals life. If your patient isn't oxygenating, nothing else matters. Airway and breathing come first every single time. Now, hear me clearly. You do not need to memorize every single lung disease to pass NCLEX. You don't need to know every medication or rare syndrome. What you do need to recognize is this: who is deteriorating, who needs oxygen, and who needs intervention right now. That's it. NCLEX is testing priority thinking. Can you spot the unstable patient? Can you recognize early respiratory distress before it becomes failure? And can you protect oxygenation? Because in real life, that's what keeps patients alive. So, in this session, we're not memorizing. We're training your brain to think like a nurse. All right, this is the slide that changes everything. This is your core respiratory framework. Anytime you see a respiratory question, I want your brain to automatically go to A, B, C, and D. Step 1, airway. Is it open? Is there swelling, obstruction, stridor, inability to speak? If the airway isn't patent, nothing else matters. Step 2, breathing. What's the respiratory rate? What's the SpO2? Are they using accessory muscles? Can they speak in full sentences? Step 3, circulation. What's the heart rate doing? Is there cyanosis? Is perfusion dropping because oxygenation is poor? Step 4, deterioration risk. Are they trending worse? Are the ABGs failing? Is fatigue setting in? Then, and this is critical, pause and ask yourself, is this patient stable or unstable? Is oxygenation adequate? That's it. If they're unstable, you intervene. If oxygen isn't adequate, you support it. This is how you stop overthinking. This is how you stop second guessing. Framework first, answer second. That's clinical judgment. All right. This is the difference between a nurse who reacts and a nurse who anticipates. Let's talk signs of deterioration. Early signs. This is your window. This is where you save the patient. Restlessness. That random anxiety, it's not random. The brain is sensitive to low oxygen. Tachypnea. The body compensates first by breathing faster. Mild hypoxia. Maybe the SpO2 is 91 to 92%. Not terrible, but it's not normal. Increased work of breathing. You have accessory muscles, nasal flaring, and can't finish sentences. These are whispers, and good nurses hear whispers. Now let's talk late signs. Bradycardia. The body is giving up. Cyanosis. You are severely hypoxic now. Decreased level of consciousness. The brain is no longer being perfused adequately. And the one that should make your stomach drop, silent chest. No wheezing doesn't mean better. It means no air movement. Late signs equal emergency, period. If you wait for late signs on NCLEX, you missed it. If you wait for late signs in real life, you're behind. We intervene early, we escalate early, we protect oxygen early. That's priority thinking. All right, this is your oxygen delivery priority rule. When you see hypoxia, don't freeze, don't overthink, just follow the sequence. If the patient is hypoxic, step 1, raise the head of the bed. Positioning is immediate. It's fast, it improves lung expansion right away. Step 2, apply oxygen. Nasal cannula, mask, whatever is appropriate. Support oxygenation. That's your job. Step 3, reassess. Did the SpO2 improve? Is the respiratory rate better? Are they less restless? And if not, step 4, escalate. Call the provider. Activate rapid response. Increase support. You don't stop at the first intervention. You reassess and decide what's next. And listen, NCLEX loves this. They will ask you, what do you do first? Which client is priority? Which finding requires immediate action? They're not testing random knowledge. They're testing whether you protect oxygenation quickly and logically. So remember, position, oxygen, reassess, escalate. That's simple, structured, and safe. This is high yield respiratory pattern recognition. When you see asthma, think wheezing. Air is moving through narrowed airways. It's tight, it's musical. When you see COPD, think barrel chest and CO2 retention, chronic air trapping. These patients live in compensation. When you see pulmonary embolism, think sudden shortness of breath with clear lungs. That's the trap. They're hypoxic, but you don't hear crackles or wheezing. When you see pneumonia, think crackles and fever, infection, fluid in the alveoli, inflammation. When you see pneumothorax, think absent breath sounds, air in the pleural space, the lungs can't expand. Notice what we're doing? We are connecting one key visual clue to one condition. That's pattern recognition. And pattern recognition beats memorization every time on NCLEX. Because when you recognize the pattern, you automatically know what's unstable and what to do next. All right, let's walk through this question like the NCLEX wants you to think. We have a client with pneumonia, and look at the cues we're given. The respiratory rate is 32, which is tachypnea. The SpO2 is 88% on room air, which tells us the patient is hypoxic. The heart rate is 110, so the body is compensating. And the patient is restless and anxious, which are classic early signs of low oxygen levels. So before we even look at the options, we should already be thinking, this patient has an oxygenation problem. Now remember a major NCLEX priority rule. Airway and breathing come before everything else. Let's quickly eliminate some options. Notifying the provider, important, but we don't call the provider before we stabilize the patient. Obtaining a sputum culture, that helps identify the infection, but it doesn't fix the immediate problem. Administering antibiotics, yes, pneumonia needs antibiotics, but antibiotics won't correct acute hypoxia right now. So, what addresses the priority? The nurse's first action is to improve oxygenation. So, the correct answer is apply 2 liters nasal cannula. This is a perfect example of how NextGen NCLEX questions test clinical judgment. You're not just asking, what does the patient have? You're asking, what will keep this patient safe first? All right, this is a classic NCLEX priority question. The question is, which clients should the nurse assess first? Whenever you see this type of question, your brain should immediately go to ABCs, airway, breathing, circulation, and who is the most unstable. Let's quickly break down the options. First, COPD with the SpO2 of 90%. For many COPD patients, 88 to 92% can actually be their baseline. So while we would monitor them, this is not necessarily the most critical patient. Next, asthma with wheezing. Wheezing tells us there is airway narrowing, but air is still moving. This patient needs treatment, but they are not yet the most unstable. Next, pulmonary embolism with sudden chest pain and SpO2 of 86%. Now, this should set off alarms. A pulmonary embolism can rapidly block blood flow in the lungs, and an oxygen saturation of 86% is severe hypoxia. This patient is at risk for rapid respiratory and circulatory collapse. Last, pneumonia with a temperature of 101. Fever indicates infection, but this is not immediately life-threatening compared to severe hypoxia. So when we compare them, the patient with the greatest threat to oxygenation and life right now is the one with the pulmonary embolism and SpO2 of 86%. So correct answer is PE with sudden chest pain and SpO2 of 86%. Remember this NCLEX tip. Hypoxia beats almost everything. If oxygen is critically low, that patient becomes the priority. All right, let's look at our third question. And this one introduces a format you may see on the next gen NCLEX, the bow tie question. Bow tie questions test clinical judgment all the way through. Instead of just picking one answer, you have to identify three things: the condition, the best nursing actions, and what parameters you need to monitor. Let's look at the scenario. We have a post-op client who suddenly develops shortness of breath, absent breath sounds on the right side, and tracheal deviation. Now pause for a second. This is where pattern recognition comes in. When you see sudden shortness of breath, absent breath sounds on one side, and tracheal deviation, that combination should immediately make you think of a life-threatening respiratory emergency. This is not subtle. This is rapid deterioration. So, in this question, the NCLEX wants you to identify what condition is happening, what the nurse should do immediately, and what we should monitor to know if the patient is improving or worsening. All right, let's break it down. The condition here is tension pneumothorax. In a tension pneumothorax, air gets trapped in the pleural space and cannot escape. That pressure starts collapsing the lung and can even shift the mediastinum, which is why we see tracheal deviation. This is a medical emergency. So, what are the priority actions? First, the nurse should apply oxygen to improve oxygenation. Second, we need to prepare for needle decompression, which is the emergency procedure used to release that trapped air and relieve the pressure. Now, let's talk about what we monitor. Two critical parameters: SpO2 to assess oxygenation, and blood pressure, because tension pneumothorax can lead to hemodynamic instability and shock. So the correct bow tie breakdown looks like this. Condition: tension pneumothorax. Actions: apply oxygen and prepare for needle decompression. Monitor SpO2 and blood pressure. And this is exactly how NCLEX questions test you. They're not asking you to memorize a disease. They're asking, can you recognize the emergency, intervene quickly, and monitor the patient effectively? Let's walk through another scenario. We have a 19-year-old client with a history of asthma who comes to the emergency department with shortness of breath after exercising in cold air. Now, that detail about cold air during exercise is important. Cold air is a common trigger for bronchospasm in people with asthma. So, right away, we should already be thinking about an acute asthma exacerbation. The key question the NCLEX wants you to answer is, can you recognize when this patient is stable and when they start to deteriorate? All right, let's walk through question number 4 together. Here are the assessment findings. The client has a respiratory rate of 32, which tells us the patient is tachypnic and working hard to breathe. The heart rate is 124, so the body is clearly under stress. We also hear audible wheezing, which is a big clue. Wheezing tells us there is airway narrowing, something we commonly see with conditions like asthma or bronchospasm. Next, the client is using accessory muscles. That means the client is recruiting extra muscles in the neck and chest just to move air in and out. Another sign of respiratory distress. Now look at the oxygen saturation. The SpO2 is 94% on room air. At first glance, that number might look okay, but this is where NCLEX wants you to think critically. Oxygen saturation can still appear normal early in respiratory distress, especially when the patient is working very hard to compensate. We also see that the client is anxious and speaking in short phrases, which tells us they're struggling to get just enough air to speak normally. So when we put all these cues together, the picture becomes clear. The client is showing early signs of respiratory compromise, and the nurse needs to recognize that the client may deteriorate quickly. This is exactly the type of scenario the NCLEX loves because it tests whether you can recognize the warning signs before the client crashes. Now let's continue the scenario. 30 minutes later, the nurse reassesses the client, and we have a new assessment finding. Now, this is where NCLEX really tests your ability to recognize deterioration. Let's look at what changed. First, breath sounds are barely audible, and the wheezing is no longer heard. At first glance, some students think, oh, the wheezing stopped. That must mean the patient is getting better. But in respiratory emergencies, the opposite can be true. If wheezing suddenly disappears and breath sounds become very faint, it may mean air is no longer moving through the airways. We call this a silent chest, and that is a very dangerous sign in severe asthma or bronchospasm. Next, the client appears fatigued. Remember, when a client has been working extremely hard to breathe, eventually the respiratory muscles get exhausted. Fatigue is a major red flag that respiratory failure may be approaching. Now look at the heart rate. Earlier, the heart rate was 124, and now it has dropped to 58. That sudden change to bradycardia is extremely concerning. In severe hypoxia, bradycardia can occur as the body begins to decompensate. Finally, the oxygen saturation is still 94%. So now the question asks, which finding indicate worsening respiratory status? Let's go through each option. First, silent chest. This is a major emergency sign in asthma because it means little to no airflow is occurring. So this is definitely correct. Next, wheezing. Wheezing actually indicates air is still moving even though the airway is narrowed. So wheezing alone is not the worst finding here. Next, use of accessory muscles. This tells us the patient is working very hard to breathe. So, this does indicate worsening respiratory distress. Next, SpO2 of 94%. Even though the patient is deteriorating, this number by itself does not indicate worsening status, which is exactly why the NCLEX includes it as a distractor. Finally, bradycardia. A sudden drop in heart rate in a patient with respiratory distress is extremely concerning and can indicate impending respiratory failure. So the correct answers are silent chest, use of accessory muscles, and bradycardia. This question is really testing one key nursing skill, recognizing when an asthma patient is moving from distress to respiratory failure. And that's exactly the type of clinical thinking the NextGen NCLEX is designed to test. Let's wrap this session up with the big picture takeaways for respiratory questions on the NCLEX. Respiratory questions are not about memorizing different diseases or every single detail about lung disorders. What the exam is really testing is your clinical judgment. First, oxygenation. Always ask yourself, is the patient getting enough oxygen? Look at oxygen saturation, respiratory rate, and worker breathing. Second, deterioration. The NCLEX wants to know if you can recognize when a patient is getting worse, especially when a condition can decline quickly. Third, early versus late signs. Early signs of respiratory problems include restlessness, anxiety, and increased respiratory rate. Late signs are much more dangerous. Things like cyanosis, confusion, or severe respiratory distress. And finally, priority action. The question is often asking, what should the nurse do first to keep this patient safe? That might be oxygen, positioning, assessment, or notifying the provider. So remember this. Respiratory NCLEX success comes from recognizing oxygen problems and acting quickly. Before we wrap up, if you want more practice like this, I've got something for you. If you're preparing for the NCLEX, the most important thing you can do is practice clinical judgment regularly. On my YouTube channel, I post NCLEX questions just like the ones we walked through today. These are designed to help you think through scenarios and prioritize like a nurse. You can also follow me on Instagram and Facebook where I share daily NCLEX tips, quick practice questions, and test strategies to keep your brain in NCLEX mode. The goal isn't just studying harder, it's training your brain to think like a nurse every single day. So, if you want consistent practice and simple ways to strengthen your clinical judgment, make sure you follow along. And as always, stay safe, and I'll see you next time.